So an intraocular lens implant is basically an artificial lens that is designed to be inserted into the eye at the time of cataract surgery. All it's doing is basically the same as what a natural lens would be doing, except that artificial lens implants are never the same exactly as the natural lens. So there are several different types of lens implants on the market, but broadly speaking, you have monofocal lens implants, which are, as the name implies, lenses that have a fixed focus. And by this, I mean they can either be, when you insert them into the eye, you can either aim to give the patient distance vision or near vision. And then you have multifocal lens implants, which are designed to give the patient both vision at multiple focal distances. So that means these lenses are designed to improve both distance and near vision. Now, the more modern trifocal type of lens implants, which are effectively a type of multifocal lens, are designed to give improved vision at both distance, intermediate, and near vision. And there are other lenses as well that are available that are, in fact, supposed to give you continuous range of vision, which means they're trying to mimic essentially a young natural lens, therefore providing visual acuity, clear visual acuity at any distance. And in the middle, there is this other type of lens implants called the enhanced monofocal lens implants, also called monofocal plus or premium monofocal. And these are basically monofocal lenses, which also provide vision at intermediate distance as well, but they do not, however, give good near visual acuity unless you aim to make the patient slightly myopic. And the point of this last lens I'm mentioning, the enhanced monofocal or monofocal plus, is that it's not a multifocal lens, and therefore would not carry the side effect profile that we know exists with multifocal lenses. And we will, in a minute, be touching on the side effect profile of multifocal lenses. So many patients seek an ophthalmic consultation with a view to being spectacle independent. And usually this is either a patient who is in their 70s and 80s and has cataract, or a slightly younger patient who is now reaching the stage where they have become presbyopic and therefore are finding it difficult to have to constantly reach out for near spectacles. And here the patient's purpose for seeking a consultation is that they would like to avoid and stop having to wear reading spectacles. To achieve spectacle independence, or often I would say to reduce the dependence on spectacles, one can either use a multifocal lens, which, as I mentioned earlier, is a lens that improves vision at multiple distances, i.e. distance, intermediate, and near. But the other option is to give the patient monovision, whereby one corrects one eye for distance and the fellow eye for near. Now, this way of giving the patient spectacle independence by giving them monovision works quite well, and is something that's been done by optometrists for many, many years with contact lenses. The use of enhanced monofocal lenses or monofocal plus lenses at the time of monovision correction has actually been a great advantage, because with enhanced monofocal lenses, it is possible to achieve a fair degree of spectacle independence without creating a big offset. In other words, without giving the patient a big difference between the distance eye and the near eye. This is important because some patients will not tolerate a bigger offset. In other words, a bigger difference between the distance eye and the near eye. And with enhanced monofocal lenses, you can achieve good reading vision, for example, with a fellow eye without necessarily using a big offset. So in other words, in terms of numbers, if you aim for 0 for the distance eye, then for the fellow eye, you can aim for a correction of minus 0.75 or minus 1, which therefore means it's a small difference between the right and left eyes, whilst it will still achieve good distance and near vision. The key thing with monovision correction is that it is absolutely essential to get the first eye, i.e. the distance eye, perfect for distance. Otherwise, you cannot anymore do monovision correction. So two ways, as in summary, are they multifocal lenses or enhanced monofocal lenses using monovision correction? So as I mentioned earlier, a multifocal lens implant is a lens that is designed to give multifocality and therefore vision at multiple distances. The main side effect profiles of these multifocal lenses is that they can give the patient halos and glare, which can be quite disturbing, particularly at night. But they can also induce dysphotopsias, so abnormal bright lights, which usually patients notice at night, so in the dark. And also, if you compare multifocal lenses with monofocal lenses, the contrast sensitivity that you achieve with monofocal lenses may not be as crisp as that with monofocal lenses, although the newer multifocal lenses are certainly of much better quality and they can certainly achieve quite good levels of vision. Having said this, I don't want to sound like it's important to bear in mind that that multifocal lenses are actually excellent lenses that have taken years to design, and certainly the very modern ones are very good lenses. And there is this process called neuroadaptation, whereby patients actually often adapt quite well to these multifocal lenses and adjust to them quite easily. Although there will always be the occasional patient who will simply not tolerate a multifocal lens, and in some scenarios, the patient may even come as far as seeking an opinion with regards to lens explantation. So the patient will come and say, I can't tolerate that lens, I can't drive at night, I can't function in the dark, I need you to take the lens out for me. Okay, I don't think I have a preferred lens implant. I think every patient, the right lens for one patient is not necessarily the right lens for another patient. So it's quite important at the time of choosing the appropriate lens for the patient to understand what are the patient's needs and requirements, and with this in mind, you have to take a number of you need to understand a number of things. What does the patient do for a living? Are they still working? Do they drive? Do they drive in the dark? Do they drive at night? Do they drive for a living? Do they spend most of the time outdoors, or do they spend most of the time on a computer or on a PC? So the right lens, the choice of the right lens really depends on the patient, and I really do not have a preferred lens. Now, having said that, if I had to say, well, what's if I had to choose a lens for achieving spectacle independence, which is often what's being discussed in the clinic with the patients, I have a fairly low threshold for using enhanced monofocal lenses with some degree of monovision correction, because they're very forgiving lenses and they're very easy to put in. They don't have any of the side effect profiles of multifocal lenses. But I still do use a significant number of multifocal lenses for some patients, particularly younger patients who seek to have spectacle independence, and therefore both lens implants I think are quite good, depending on the patient you're trying to treat.